Good morning and welcome to another video for PW 1002. Today we're going to be looking at medicines prescribing, dispensing and administration, roles and responsibilities. So this links into your module learning outcomes because it links to learning outcome 2, discuss and apply your knowledge, understanding of how medicines are prescribed, administered and managed in healthcare. And it also links into learning outcome 4 of identifying and applying the principles of safety in medicines management and administration. Excuse me. So over this session we're going to be looking at the introduction to medicines and prescriptions. We're going to be exploring some of the key issues in relation to medicine supply and storage, and we're going to be identifying some of the roles of healthcare practitioners and their responsibilities regarding safe medicines management. Now, as I said before, I know quite a lot of you don't actually have anything to do with the administration and prescribing of medicines directly, so don't worry too much about this, but it's just to give you that basic understanding and kind of background knowledge for your theory so that you understand some of the principles and some of the things that the practitioners around you who are administering or prescribing medications actually have to think about. So some of these slides are a little bit wordy, I do apologise, but there's lots of information for you to gather from this week's sessions. At the bottom of some of the slides there's also links to help you to take you to further information, to further reading, and some of these are also the links that were in the week 1 resources button within your OneNote notebook. So again, have a look at those if you have time, do a little bit of further information, but the things that are in the further information aren't going to be key for your exam. I'll highlight anything that's going to be key for your exam as we're going through, but other than that I'll give you a brief overview of the information on the slides, and then you'll have to go back and have a look through the slides in your own time and complete the tasks on the task sheet and the case study at the end of this presentation. So when we're thinking about medicines optimization, we're thinking about a person-centered approach to safe and effective medicines use, to ensure that people obtain the best possible outcomes from their medicines. So we're thinking about having an individualised care for our patient and making sure that all the things that we present to our students and all the information that we present to our patients are individualised, and that the medicines management that they're getting is very specific for their care that they need to receive. So a couple of stats for you. A quarter of the population has some kind of long-term condition, and a quarter of people over 60 have 2 or more long-term conditions. So when we're thinking about our medications management and we're thinking about our patients, quite a lot of our patients, especially if they're over the age of 60, are going to be having multiple medications to treat their underlying long-term conditions. And within this ageing population, the use of multiple medicines, and this is also known as polypharmacy, is increasing. So it's really key that we have a basic understanding of our medicines management, because it's really going to be thought of and affecting our patients or the patients that we might be working with. So it's really important that we understand this. But of these medications, about 30 to 50% of them that are prescribed aren't actually taken as intended. So patients might actually not be following the prescriptions, they might be taking them at inappropriate times, they might not be taking them with food or without food or at the prescribed times. So it's really important that we help our patients to understand the importance of following their prescriptions, following their instructions that they've been given, to be taking them at the right time and with the right food or not food or anything else that's really important. And the key thing of medicines optimization is it helps to improve our patient outcomes. It helps them to understand the reasons as to why they should be taking their medicines correctly, and it helps the patients to avoid taking unnecessary medicines. And obviously in the long term of this will also help to reduce wastage of medicines. And obviously this is going to save the NHS money, it's going to save the government money across the board, and it's also going to improve medicine safety, because if our patients are taking their medicines as prescribed, We know that if there are any side effects or any problems, how we can support that patient. If a patient isn't taking their medicines appropriately, it's very hard for us to say what the problem is and why that medication may or not be working for the patient. So the NICE guidelines have some standard contributes to help us to improve medicines improvements and to help our patient outcomes. And obviously this is the link, if you click on further down, it'll take us to the NICE Medicines Optimations guidelines. But an overview of these are that it helps to reduce harm attributable to errors in medication. It helps us to improve patient satisfaction with their outcomes. It helps to improve the quality of life for people with long-term conditions. It helps to prevent preventable mortality. It helps to reduce preventable morbidity. And it helps to improve the life expectancy for people with long-term conditions. So it's really key that we have a good understanding of medicines optimization and why it's so important. If we're thinking about our legislations and our guides in a little bit more detail, the key one that's going to help us is the Human Medicines Regulations from 2012. So some of the key things from this is thinking about our medicinal products. And within the regulations, medicinal products mean any substance or combination of substances presenting of having properties or preventing or treating diseases in human beings. Any substance or combination of substances that may be used or administered to human beings with a view to restore, correcting or modifying a physiological function by exerting a pharmacological, immunological or metabolic action, or it might be something that helps us to make a medical diagnosis. Obviously within this we've got a lot of information that is focusing directly on human beings. And this is because the Human Medicines Regulations only cover the guidance for medicines which should be taken by people. There are also a lot of regulations out there that help to support medicines that are taken by other animals, if we're thinking about veterinary medicine and we're thinking about other medicine out there. And there might be some crossover with some of these medicines being able to be taken by different members or kind of organisms within society. But the one that we're really focusing on today is Human Medicines Regulations as opposed to anything that might govern veterinary medicine. So when we're thinking about our prescribing of medications and we're thinking about the medications that our patients might be receiving, we've got to think right back from the beginning. So we've got to think about the manufacture of these medications. Who actually sells these medications? Is it the drug companies themselves? Have they been able to go out to any provider to be able to create? Who are they prescribed by? Who are they dispensed by? How are they stored? Who are they administered by? And who actually monitors these? So obviously this is quite contemporary at the minute when we think about, what's happening with COVID and we think about how all these things have gone focused. At the minute, a lot of these COVID vaccinations and COVID medications are still in the manufacture stage. They're still in the stage where we're trying to decide, can we actually create medications that are going to be used to help treat COVID? How do they work? Who's actually providing these medications? Once they go from there, they're going to pass through the rest of the stages. And obviously at the minute, we don't know who's going to be selling these. Is it going to be coming from the drug companies? Is it going to be coming from the government? So it's quite an interesting thing to be thinking about at the minute, especially with the issues that we are having with COVID. And as it says, a little quote from the RCN here, it's preferable for the actions of prescribing, dispensing or supply and administration to be separated and to be performed by different healthcare professionals. So when we're thinking about this is really key, because actually if we're thinking about this, we've got to look at the underlying factors. There might be biases, there might be medical prescribers who are actually, very focused on making sure that only one type of medication is used because they feel that that's the best. Or as that used to happen historically, if we're thinking about, the good old days where drug companies could come in and try and sell you their products, they might actually buy prescribers through using gifts, through using other things to try and sway a particular prescriber to prescribe a certain medication. Now in the UK this isn't allowed anymore. We've got to have equal opportunities for all medications, whether they be from specific drug companies or different drug companies. But it's really key when we're thinking about this that actually around the world some of these limits aren't actually on. So if you look to, for example, the American healthcare system, these drug companies can still provide maybe monetary gifts to prescribers or other types of gifts to prescribers for them to actually have a bias towards a particular medication. So it's really important that we look at the ethical principles around the supply and administration of medications and how this might affect the patient and the patient's outcomes. So when we're thinking about this, we've got to really start after the drug has been manufactured, it's been created, it's out there into the real world. What is the role of the prescriber? Now there are lots of different guidelines and things that are covering a prescriber, but really a prescriber should be aware of the particular illness or long-term condition or problem that the patient has, to have probably been part of the diagnosis of that particular issue, to have a full understanding of what it is that the patient might be requiring. So the role of the prescriber is to prescribe drugs or a treatment, including repeat prescriptions, only when they have adequate knowledge of the patient's health and they are satisfied that the drugs or treatments will serve the patient's needs. This means that the prescriber shouldn't be going off and thinking, well, we'll give it a try, it might work, this might be the best thing. Now I know this sometimes happens in practice because, again, when we've got to think about the patient's needs, it might be that they need to try something to have a better outcome for the patient or to have a better long-term overview to be able to have a better quality of life. But they should be providing effective treatments based on the best available evidence at the time. Obviously this might change as we've looked at in previous sessions. We're looking at best available evidence at the time. When we look historically back over things that have been prescribed, we discussed some of the things that were prescribed maybe inappropriately in the past, and we looked at examples of things like smoking that was actually prescribed for chest infections and improving respiratory illnesses, because at the time the best available evidence out there said that this was a really, really good treatment for that particular long-term condition. However, as research has progressed, as things have moved forward, we now look back and think actually maybe that wasn't the best thing for us to do, and there are different treatment pathways that are available currently. So it's really key that we are keeping ourselves up to date, that we are using evidence-based practice, and we're making sure that the information that we're using is contemporary and not outdated. And we also, as a prescriber, or the role of the prescriber, is to check that the care or treatment that's being provided is compatible with any other treatments the patient is receiving. And this is really key that we also look at any self-prescribed over-the-counter medications. It's really important that a prescriber is looking at any interactions, any side effects of taking certain medications together. There is quite a lot of evidence out there that especially over-the-counter medications, maybe some vitamin treatments or other herbal remedies can actually have an interference with any prescribed medications that the patient might be taking. Now this might be something like they're taking St. John's wort to try and perk themselves up, which can have a major impact upon other medications that are being taken when we think back to the pharmacokinetics and pharmacodynamics of a medication. But it might also be something as simple as making the patient aware that something like grapefruit or grapefruit juice might actually have an impact upon medications that they're taking, and again cause issues with the pharmacokinetics and the metabolism of the medications that they've now been prescribed. So it's really important that when the prescriber is actually interacting with the patient and making them aware of why they need to take this medication, how they need to take this medication, that they also need to be aware of anything else that might be key to the medication's success. Again, there's another document at the bottom of here that's looking at the General Medical Council, and it's looking at their prescribing guidance and the things that they say that prescribers should be aware of. So again, I know you're not always part of some of these prescribing processes, but there are several different ways that patients can have medication prescribed. So it might be that they're having it prescribed from an independent prescriber. So this might be a practitioner who has undertaken further training, that they've actually completed a course, that they aren't necessarily a doctor, but they are able to prescribe under the independent prescribing mechanisms. It could be that they're a supplementary prescriber. They haven't actually completed an independent prescribing course, but they are able to prescribe certain things to support a patient. But these tend to be very specific, and they're working within an agreed patient-specific clinical management plan, so that the patient and the person who is prescribing supplementary is able to support them and to support each other and to support all the members of the multidisciplinary team. It might be that you're working under patient-specific directions or patient group directions. So these tend to be for certain medications, might be examples like flu jabs or vitamin B injections, where you aren't actually the prescriber for the medication, but you're working under a patient group directive, which is saying in a certain situation the patient is allowed to have this medication and you're allowed to administer it without that medication actually being prescribed by a practitioner. So obviously in the case of, for example, the flu jab is offered to certain populations or certain people within the population, and as long as they satisfy certain criteria, the practitioner is able to give the vaccination or the vitamin B injection following the specifics of a patient-specific or a patient group directive. And again, at the bottom of this page, we've got some more information from the NHS as to the kind of things that might be supporting prescribing or different methods of prescribing within our patient population. Once the patient has had their medication prescribed, we then have to think about how it's actually written down. So this is called transcribing. So transcribing can be defined as the act of making an exact copy, usually in writing. And it's the copying of previously prescribed medication details to enable their administration. And that's from the Royal College of Nursing. So if we're working within a hospital setting, this might be the creation of a medication administration record or a MAR chart, so that the healthcare professional can then administer the appropriate drugs at the appropriate time to support the patient within hospital. This might be that the medication chart is then followed by the patient if they're self-administering their own medications, or it might be that it's then followed by a practitioner within the hospital setting who is then administering certain medications at certain times because they've been prescribed by a prescriber. So once we've thought about the prescribing of the medication and how the medication is actually given to the patient, we also have to think about the fact of how our medication should be stored. So how should non-controlled and then going on to controlled drugs be stored? Now obviously we're mainly focusing on within a hospital or a health setting environment. Within a patient's home, there might be a lot of differences. There might be recommendations that should be happening within a hospital, which obviously when we're looking at a patient's home, these are going to be completely different. So if we're thinking about non-controlled drugs within a hospital setting, Non-controlled drugs should be either kept in a lockable drugs trolley that should be then able to be moved around the ward or around the hospital setting, so that every individual patient can actually be supported and be watched, because we shouldn't be carrying medications around a hospital or ward setting, because this is one of the things that can help medication errors to occur. It might be that these lockable drugs trolleys are a general ward trolley, or it might be that we're thinking about the patient's individual lockers these days that have a lockable part to them where an individual patient medication is kept. So rather than having a general store of medications on a ward, to try and reduce this, we're now using the patient's own prescribed medication when we're in a hospital setting. Or it might be that certain medications have to be kept cool, and they have to be kept within, again, a lockable medication fridge. These fridges need to be monitored regularly, and they're there to help support medications that might lose their effectiveness unless they're stored at a certain temperature. For example, insulin or bags of IV antibiotics. And as I said, this needs to be checked regularly to make sure that this fridge is actually still within safe limits, so that these medications aren't going to denature in any way. So the storage and maintenance of these medications might be looked after by different people depending on the service that you're working on. It might be the responsibility of the practitioners on the ward to maintain these, to check use by dates, to check stock levels. Or more and more it's becoming more frequently for pharmacists to actually visit these hospital settings, and they are actually maintaining the stock levels, the use by dates, and making sure that all the medications are actually kept in the manner that they should be being kept. So it's really important that you're aware, if you are working in hospital settings, to understand what the policies and the procedures are in the area that you're working, so that you are following them correctly. When we think about controlled drugs, there is a slight difference to this, because controlled drugs are also covered by the misuse of drugs regulations. And these state that our controlled drugs should be kept in a locked cupboard within a locked cupboard, which is wall mounted, that it's not easily accessible. It needs to have a light that's displayed in a populated place, for example the nurse's station, and the cupboard itself when the inner cupboard is open, to alert people that somebody is actually going into the controlled drugs cupboard. And a register must be kept of the quantity of the controlled drugs, so that we're aware of any drugs that are being held that are controlled by the misuse of drugs regulation at any one time. This register must be kept up to date, and it should show the date, the time, the name of the patient, the dosage received, the number of controlled drugs remaining, and the signature of the person administering the drug, and a second signer, the witness. Now, it might be that it's part of your roles and responsibilities that you can actually be a second signer for controlled drugs. You can't administer them directly, but you can actually second sign as the witness to the amount of controlled drugs which are within the cupboard. So the administrator of the drug must be a qualified nurse or doctor, or in some cases, if it is within your roles and responsibilities, it might be the assistant practitioner. And you've got to have the witness, who again must be an appropriate member of staff. It's just again back to, is it in your trust policy or your working policies and procedures as to who can and can't be the administrator or the second signer for these controlled drugs. The cupboard must never be left open, and if there is a discrepancy, then the nurse or the person in charge must be informed immediately. And again, the appropriate policies or procedures should be followed to make sure that any discrepancies, any missing, any spillages, any issues are reported and followed. It's really good practice when we're thinking about medication management to think about what needs to be checked on a regular basis. So as I said, staff should check expiry dates and the quantity of the medication in stock. This might be up to the staff in charge, or it might be, as I said, up to the pharmacist who visits the hospital setting or the setting that you're in. They need to be checking fridge temperatures, and it's really important to make the medication cupboard or fridge clean and orderly. Again, we're thinking about infection control, infection prevention. We think about what's happening with COVID at the minute, and it's really important, if we are handling things in between patients, if we are administering medications to our patients, we've got to think about medicines management. We've got to think about the transmission of our pathogenic microorganisms and how we might be potentially affecting our patients. If we don't follow basic infection control policies, we aren't washing our hands and we aren't doing what we need to be doing in between our patients. Any old stock which is unneeded should be returned back to the pharmacist. And a lot of policies and procedures within your areas might be that weekly stock checks are taken, and it might be that these are taken once per shift, or it might be taken that these are taken once per week. And again, they might be carried out by the pharmacist, or they might be carried out by the general staff within that area of work. When we're thinking about our essential information and we're thinking about our prescriptions specifically, there are some key things that should be written on a particular medication chart, or that should be aware of. So we should be writing in generics. Sometimes this might not actually be appropriate. Sometimes patients have issues with generic types of medication. As it says, there might be some bioavailability issues. Patients might only be able to take certain types of medication. There might be that certain types of medication, especially if we're thinking about our patients who might have additional things for us to think about, for example, vegetarians and vegans, or patients from other cultures who can't take certain medications because they're created using gelatin capsules, or they're created using certain medication proteins. Some medications are based on eggs, some medications are based in with maybe milk or wheat proteins. And it's really key that if our patients have any issues with these things, that the prescriber is thinking about using specific names of medication if it is appropriate, compared to the generic name of the medication, which could mean that any version of that medication can be given. We should be avoiding any unnecessary use of decimal points. So again, it's really key that we should be writing in the appropriate format. Obviously, this is going to link into the maths session that we're going to have a discussion of later on, but it's really important that when we're thinking about that, we should be making it easy for the administrator to be able to help and support the patient with their medication, and that we're not bringing in any unnecessary workings out for the administrator, so that we aren't helping any medicines administration issues. Everything should be written in English without using any abbreviations. However, there are some times that we might be using our Latin abbreviations. These can be found in the BNF, but examples of these are things like STAT, which means immediately, or PRN, as required, OD, every day, ON, every night, BD, twice daily, TDS, taken 3 times a day, or QDS, taken 4 times a day. It's really, really important that we are aware of what these abbreviations mean if we do have to work with them, if we've never seen them before. If we're ever unsure of anything, always go and ask a different person to help support you, or just to confirm if you're unsure. Again, we should also state the minimum dose intervals and maximum total amounts, again, so that we know whether we're underdosing or overdosing our patients. If a treatment is over a particular number of days, this should also be highlighted on the prescription chart or the Mars chart, again, so that people are aware of when this medication should be started, when this medication should be stopped, and over how many days it should be given. We should be specifying the strength, and the quantity, again, to help people be aware of how many they might need for this particular patient. We should be writing on the prescription in inverted commas anything other than the name, strength or the dosage. So if there's something that we really need to key on the particular prescription chart, we should be making sure it's in those inverted commas if it is appropriate to have on. And we should be avoiding abbreviations of drug names because, again, these can be misinterpreted. So it's very important that we're thinking about making our prescription charts, our Mars charts, as easy to read and to follow as is possible. Otherwise, medication errors might occur because of misunderstood or misfollowed information. There's some more information at the bottom of here of general prescribing guidance. When we're thinking about our patients and we're thinking about our key things, there are 5 key pieces of thought when we are administering medication. Now, in some focuses, these are referred to as the 6 R's of medication. They might even be referred to as the 7 R's of medication management. But we're going to look at the 5 R's of medication management, which are the basic necessities. And these are the ones that are going to be referred to within your exam. So the main 5 R's of medication, or the 5 rights of medication, are the right patient, the right time, the right dose, the right route, and the right drug. If we've got those 5 basic rights, we then know that actually our patient is the correct patient. We're giving them the right drug at the right time with the right dosage, and we're giving it through the right route. So it's really, really key that if we are involved in medication administration, that we're aware of these 5 R's of medication administration. So when we're thinking about our tasks, there are some key things that we have to think about. And these are some of the steps that should be taken when administering medication. We should be thinking about our infection control and infection prevention. We should be washing our hands. We should be making sure that we're explaining to the patient what we're doing and that we can gain consent. You know, patients have the right at any point to refuse medication. So it's really, really important that we say, you know, hello, Mr. Such and Such, it's now time for your medication. You're going to take X, Y, and Z tablet. Here they are. It's important that you've got your prescription chart, that you then check your patient details, and we're starting to think about your 5 R's of medication management. We need to check that the medication is due and it's not already been given. Sometimes medication errors happen because practitioners don't always check the medication charts, will give the medication and then realise that actually another practitioner has already given this particular patient their medication because they asked for it earlier. We then have to check our 5 R's again, our right patient, right time, right dose, right route, right drug, and then check that they have been prescribed if we're following a Mars chart or a prescription chart, that they have been prescribed properly and that the prescriber has filled all the paperwork in. We then need to check that we have the medication within the trolley, that the medication is the right dose as it is on the box, as it is on the packet, and that medications haven't been mixed up by accident at a different time. We need to check the expiry date on the medication. Even though, as we said earlier, these medications should have already been checked regularly, these things can slip through, accidents can happen, and it's really important that we need to check all these things on our medications before we give them to our patient. We need to empty the required dose into a medicine pot or draw it up into a syringe if it's being administered in a different method. And we need to make sure that, again, we're following the no-touch techniques, that we are thinking about our infection control methods at all times. And we're also thinking about our own personal safety. If you're working on a place where you're dealing with a lot of specific types of drugs regularly, and you're coming into contact with them maybe 10, 12, 20 even times a day, we could be inadvertently dosing ourselves with medication if we aren't following appropriate no-touch methods. Again, we should be checking the patient's identity to make sure that they are the correct patient before we give them the little pot or whatever medication it is. Again, checking for any allergies, making sure that they're both noted on the medication chart and an allergy bracelet if appropriate. And then offer a drink and make sure that the patient swallows the medication. We shouldn't be popping pots of medication on tables or near patients and hoping that they'll then take them at a later time. We need to be watching our patient take their medication. So again, we can make sure that our patients are taking their medication at the appropriate time, that they aren't stockpiling to take at certain times. And this is especially important with medications if they do have certain time requirements or intervals between them. And then you need to sign the prescription chart immediately. If there are any extra issues that you need to note down, that the patient's reported any side effects, that the patient wasn't there at the time that you went to give them the medication so you couldn't give them, or that the patient refused the medication, these also need to be documented. And if you've got any problems, you always need to check with your organisation's policy and procedures. Medication errors are a really key thing we've got to think about when we're thinking about dealing with any medications within our practice. So a medication error is a failure in the treatment process that leads to or has the potential to lead to harm to the patient. These are really key. Not all medication errors are direct errors with the patient. They might be near misses. Think to your IR1 forms or other risk assessment documentation. We also have to think about near misses as much as we have to think about, direct medication errors. This could be something as simple as an out-of-date medication still being within the medication stock. It could be that packets of medication haven't been put back in the right boxes and they've been mixed up. These still need to be reported as medication errors or near misses as much as anything that's a little bit more dangerous. So medication is the most common intervention in medicine, and it's a critical component of modern healthcare, with over 1 billion prescribed items being dispensed in the community in 2016. So medication also represents a substantial total cost to the NHS, being the second largest outgoing in the NHS after staff costs. The total net ingredient cost is over 9 billion for prescription items dispensed in 2016 within primary care alone, and about £16 billion for total annual drug expenditure. So when we're thinking about medications, it is a really, really key thing. And it's one of the things that's with the NHS and healthcare in general spends the most money on, as it says, after staff. And an estimated 237 million medication errors occur in England every year. So these can range from minimal things or near misses to major medication errors which could have a life-altering outcome for the patient. And the economic impact of medication errors varied widely from £60 errors for inhaler medication to more than 6 million in litigation costs associated with anaesthetic errors. So again, it could be something as simple as a patient was prescribed something in error and they didn't need that medication. Or, as I said, something a little bit more sinister has occurred and actually the trusts are being taken to court because of big problems that have affected a patient. Errors were more likely to occur in older people, in patients with multiple conditions, and when using many medications. So it's really, really important that we are aware that medication errors happen, that medication errors aren't inevitable but do happen regularly, And it's really, really important that we are thinking about these things when we are administering medication, or we're thinking about these things when we are supporting our fellow practitioners to administer medication. And again, there's some more information down there at the bottom of the slide that you can look at from the government that's going to actually talk about reports on medication errors if you're interested in looking at those in a little bit more detail. So when we think about medication errors, some of the most common medication errors not related to dosage calculations, not relating to the math side that we're going to look at later on, are wrong patients. So patients being given the wrong medication. So things like similar names or similar looking patients, mix-ups when second nurses are involved. You know, patients thinking, oh, go and give this to Betsy in bed 2, where there's also a Betsy in bed 4, and all the patient is actually, all the staff members listened to was Betsy and didn't necessarily double check which bed the patient was in because they weren't following the appropriate policies and procedures. It might be wrong doses, so again we're thinking about prescription errors, administration errors, so it might be omissions, patients aren't given medications at the correct time or they're missed altogether. They might be given after treatments being completed if a patient's been on antibiotics for a 7-day course and then it hasn't been given an end date within the medication chart. Excuse me. They've been given a continuing treatment even though their official treatment course is finished. It might be that they've been given the wrong strength of medication, or they've been given a double dose of medication because prescription charts haven't been followed or prescription charts haven't been signed appropriately and second nurses have come along and given medication again. It might have been that it's been given by the wrong route, so it might have been given orally instead of by injection or intravenously or vice versa. It might be that it's been given at the wrong time, so again we're going back to these 5 R's. So that Parkinson's drugs, for example, need to be given at a specific time, but they've been not given at the right time. It might be that they've been given with food or without food, and that we haven't followed the procedures properly. And this is probably one of the key ones, because even though medication rounds are, they tried to be done at a certain time, we all know that the nature of healthcare is very fluid. And sometimes this can lead to medications rounds being early or being late, or medications not being given at the appropriate time. Or it might be that the wrong drug has been given. So again, similar looking pills or packaging. It might be the mislabeling with contents not being checked against the packaging. So as I said, you know, it's very easy if you're putting, you know, 4 or 5 medications out for a patient, that when you're popping the little foil packets back into the boxes, that 2 of the boxes have just been mixed up and then the next person's come along, not checked, and they've actually ended up giving the wrong medication to a patient, even though they thought they got the right box out. So it's really, really key when we're thinking about medication errors to think about what they mainly are and what this could actually mean, and how easy it is, if we're following the appropriate policies and guidance, to hopefully try and reduce some of these medication errors. Now, there are some strategies to improve medicine safety. So have a look at your own organisation's policies to look at what kind of things have been improved or what kind of things have been implemented to help with medicine safety. Now, this is just one of the examples that is used in some wards in some areas, that the nurse who is actually on the medication round wears a do not disturb tabard because they're trying to identify them that they are on a medication round, so that if a patient or another staff member is in need, that they would try and contact a different member of staff so as not to disturb the medication round person, so that they don't get distracted, they don't miss patients, they don't accidentally double up on medications, and some of the basic medication errors that can occur. So that unless it is an emergency and you need all hands on deck, that this particular practitioner can actually complete the medication round undisturbed. So have a look at what's out there, have a look at what your particular area of work does to try and reduce some of these issues. We also have, as I said, linking to our codes of conduct. We have our NMC code of conduct here. We have the links on your resource page to the HCPC codes of conduct. And it's really important that if you are working in an area that is supported by standards or a code of conduct, that you are looking at them in line with your policies and your procedures as well, to think, you know, what is key, what are the things that I have to be aware of. And even if you're not directly involved in the prescribing or administration of medication, you know, what are the other practitioners that are working around you bound by, and what things should you be aware of that they need to be doing? Remember, we are working as a whole multidisciplinary team, so it is really important that we're aware of these different things. So when we think about accountability, you've probably all written loads about accountability. You've looked at accountability, it links into your apprenticeship standards. And accountability is about taking responsibility and being answerable for your decisions and actions and the consequences of those actions. So what this means, and this isn't just for anybody who's involved in the prescription and an administration of medications, it's also really key when we're thinking about our roles in general, is to think about, do you know why you're doing what you're doing? Are you doing it because it's best evidence, or are you doing it because that person over there told you to? Have you been properly trained and assessed as being competent to do what you're doing? Again, think about your portfolio, think about your apprenticeship standards. Again, this is why we do your portfolio. This is why you have your work-based learning time. You know, are you doing something that you are competent in? If you aren't competent in it, or you haven't been assessed as being competent in it, should you be doing this thing? And you should be doing it as part of an agreed care plan for the patient. If it hasn't been agreed, why are you doing it? Again, has somebody told you that you should be doing it? Or has the care plan not been updated appropriately? Make sure that you are aware of why you're doing what you're doing, so that should anything happen, you can always back it up by saying, I do know this, I was doing this correctly, and I'm not sure what went wrong. Obviously this links into our record keeping. Record keeping's really, really key just in general across the board. It links into our apprenticeship standards for communication, it links into our apprenticeship standards for good documentation, and it's really, really key when we're thinking about medicines management that we need to make sure that everything is there so that other members of staff are aware of what medications have been taken or not taken and how this could affect the patient. You know, there's some key principles here on this page, thinking about they need to be completed at the time, they must be signed and dated, they must be accurate, you know, they should be stored appropriately. You know, we were always told when I was doing my training, you know, if it's not written down, it didn't happen. If you've got no written documentation that was completed, as it says, at the time or as soon as possible after the event, it doesn't matter if you can say, yes, I did that, yes, of course I did that. If it's not written down, it didn't happen. There's no proof that you did that. So record keeping is really, really key, especially when we're thinking about medicines management. Again, it links back into those medication errors. If we can prove that it happened, if we can document that these things have occurred, we're less likely to make other medication issues with other people coming along and either giving medications again or errors occurring. So last couple of thoughts really before we get into the end. So what things would you do if a patient refuses to take the medication? Obviously patients have the right to do what they feel is best for them. And if a patient refuses to take the medication, you've just got to follow the trust policy. We don't have a right to insist that a patient takes it. We need to make sure that they have all the appropriate information so they're aware of why they're taking a particular medication, the benefits of taking a particular medication, so that that patient can have true informed consent. If that patient is still refusing that medication, again, it's absolutely fine. We shouldn't be trying to covertly administer medication. There are certain circumstances, if it has been agreed within a care plan, and it's been agreed by multiple practitioners as part of a multidisciplinary team, that covertly administering medication might be appropriate. But in the general, covertly administering medication is not appropriate, and it's against trust policy and guidelines. We should be recording the refusal. What were the reasons that the patient refused the medication? Was it something as simple as they felt nauseous and wanted to take it later, or they had been being sick? Was it that they weren't aware of what this medication was and they wanted more information from the prescriber before they actually took that particular medication? Was it that actually they didn't believe they should be taking that medication anymore and they wanted to talk again to the prescriber about why they were still receiving that medication? So there might be certain reasons or certain underlying thoughts as to why the patient is refusing their medication. And it's really, really key that you work alongside the patient and that you don't just write refused without any further information to help support other members of the team to actually get to the bottom of why this patient is refusing certain medications. Again, you should be reporting it to whoever the nurse in charge is or the practitioner in charge is in that particular area, because again, this needs to be followed up and to find the underlying reason as to why that medication has been refused. And you need to contact the prescriber if it's appropriate. Again, that patient might just feel that they don't have enough information, or they've been told one thing off one person and one thing off another person, and they're very much confused. Remember, consent comes back down to informed consent. And if a patient doesn't feel informed, they can't fully consent to the medication. So it's really key that we think about what are the reasons that patients are refusing medication and what can we do to support them within that choice. We now have case study. The case study is for you to be looked at in a little bit more details on your tasks this afternoon. So the introduction to the case study is about Sandra. Sandra's been prescribed an antibiotic for a urinary tract infection. However, you notice a rash developing on Sandra's chest following the administration of the first dose. You've been instructed to give a second dose. What should you do? So on the next slide, there's a couple of options. These are repeated on the task sheet. So again, have a think about these different options, have a think about what we've looked at today, and have a think about some of the policies, procedures and legislations that underpin medicines management when we're thinking about how we might actually support Sandra and think about what we want to do going forward. So lastly but not leastly, within this presentation, we've looked at your role in maintaining high standards and good practice in the storage, dispensing and administration of medication. And this is really, really vital. As I said, even if you're not directly responsible for the prescription or the medication of, the administration of medication, it's really, really important that we have that basic understanding when we're thinking about these things to support our patients and to support our team members. And that keeping accurate, legible and up-to-date records, not just in medicines management but across the board, is essential to make sure that we are following our role and responsibilities appropriately. So the last slide of this presentation has a few additional references, some references from in the presentation that can support you. There's also the links within the presentation that you can go back and have a look at, and there's the additional resource sheet within the OneNote notebook again that you can go back and have a look at. So now, any questions, any issues, thoughts, problems, worries, fears, feel free to contact me, Teams me, pop the messages on there. We can have a chat about them in the seminar this afternoon. Complete your tasks, which again are on Blackboard, they're on the OneNote document, and they're on Teams themselves. So have a look, try and work through the tasks, try and think what you'd do for Sandra. Think about what your role might be within medicines management, and then we'll have a more in-depth discussion this afternoon. So I know it's been a bit of a longer one today, we're at like 55 minutes, but there was a lot to get through today when we're thinking about our roles and responsibility with prescribing, administering, storage of medication. So it is really key that you listen to me, that you work through the PowerPoints and the links in your own time, and then that you complete the tasks ready for the discussion. So I shall see you later, and have a nice day. Bye.